Welcome to today's Explainer. We're going to kick things off with a totally fascinating clinical mystery that sits right at the very heart of modern cardiology. Imagine, if you will, that you have two patients. Both of them just had an echocardiogram that shows severe mitral regurgitation. They both have that similar-sounding pansystolic murmur, and both of them are sitting right there in your clinic breathless. On paper, they look like they have the exact same problem. Okay, let's dive into this, because as we're going to see, their treatments literally couldn't be more different.
Here is the real paradox. For patient 1, the echo reveals a floppy, prolapsing valve leaflet. The valve itself is physically broken. But for patient 2, the valve apparatus is perfectly structurally normal. There's actually not a single thing wrong with those leaflets. Instead, the ventricle around the valve has dilated, essentially dragging those completely normal leaflets apart. So, same murmur, same diagnosis of severe MR, right? But one of these patients desperately needs their valve fixed, while the other, in a really specific and increasingly important subset of cases, might actually need their heart failure fixed first. By the end of this explainer, you'll know exactly how to tell these two patients apart, and you'll understand why their treatment pathways diverge so sharply.
To solve this mystery, let's jump into Section 1, the leak with two origins. We first need to establish what's actually happening mechanically inside the heart. Ultimately, all mitral regurgitation fundamentally comes down to a failure of coaptation. Basically, during systole, when the heart gives that big squeeze to pump blood out to the body, the mitral leaflets are supposed to snap shut and form a really tight seal. But in MR, they just fail to meet. Because that seal is broken, instead of all the left ventricular stroke volume going forward into the aorta like it should, a portion of it regurgitates backward into the left atrium. And this is key. That backward flowing blood has to go somewhere. Everything that follows in this disease is a direct consequence of where that extra volume goes. But before we can even begin to predict those downstream consequences, I want you to ask yourself this crucial question whenever you're looking at an MR patient. Is the valve itself the problem? Or is the valve just an innocent bystander to a problem happening somewhere else in the heart? This isn't just some philosophical debate. It's literally the entire organizing principle of all modern mitral regurgitation classification.
Let's see how this builds our diagnostic decision tree as we move into Section 2, primary versus secondary MR. This really brings us to our first major fork in the road.
We divide MR into two main branches. On one side, we have primary, or organic MR. This means the actual parts of the valve, the leaflets, the chordae, the annulus, are structurally abnormal. The logic here is super straightforward. Fix the anatomy, you fix the leak. Now, on the other side, we have secondary, or functional MR. This is the exact opposite logic. The valve parts are completely normal, but the valve has become a victim of ventricular disease.
To briefly outline what physically breaks the valve in primary MR, well, the most common culprit by far is myxomatous degeneration. The leaflet tissue just becomes redundant and floppy, causing it to prolapse. You can also see primary MR from rheumatic disease, infective endocarditis, where bacteria literally destroy the leaflet tissue, or a chordal rupture from something like trauma. In all these cases, a surgical repair has excellent, incredibly durable outcomes because you're just going in and fixing a mechanically broken part.
But over in secondary MR, the problem actually originates below the valve. Usually, because of a prior myocardial infarction or a cardiomyopathy, the left ventricle dilates and remodels. As it expands outward and downward, it drags the papillary muscles with it. This physically tethers the chordae and pulls those normal leaflets apart, so they can't meet in the middle anymore. The valve is really just caught in the crossfire of a failing ventricle.
And this brilliantly illustrates a much newer, sharper distinction that's emerged in modern cardiology, taking us right into Section 3, ventricular versus atrial secondary MR.
You see, secondary MR itself is now split into two totally distinct phenotypes. What we just described, where the left ventricle dilates and pulls the muscles apart, that's ventricular secondary MR. But there's a genuinely distinct entity called atrial secondary MR. In this scenario, the left ventricle is actually normal, or at least near normal. Instead, a severely dilated left atrium, very often from long-standing atrial fibrillation, stretches the mitral annulus itself. If the ring around the valve gets overstretched, the leaflets simply can't close the gap, even with normal ventricular geometry. So the leak originates from atrial stretching, not from ventricular pulling.
Now that we know why the valve is leaking, we have to look at how the heart adapts to this chronic volume overload in Section 4, the ejection fraction trap. And a quick warning, definitely do not use a mitral stenosis framework here.
We all know cardiologists love a good plumbing analogy, right? Well, this creates a vicious cycle of volume that would absolutely shatter any normal pipes. Step 1. Every single time the heart beats, the left atrium receives the normal blood returning from the lungs, plus the blood shooting backward through that leaky valve, so it massively dilates. Step 2. In diastole, the left ventricle now has to accept this double volume all over again. Step 3. To cope with this, the ventricle develops chronic eccentric hypertrophy. It dilates just to hold all that blood. And step 4, especially in secondary MR, this creates a total doom loop. The ventricle dilates from the extra volume, which pulls the valve further apart, which causes more leak, which causes more volume, which causes even more dilation,
which leads us straight into a really counterintuitive trap. I want you to think about this for a second. Why is a normal ejection fraction, which is usually a great sign of a healthy heart, actually dangerous when we're talking about severe mitral regurgitation? Well, here is the twist. Because that mitral valve isn't sealed up tight, the ventricle essentially has two exits, the high-pressure aorta and the low-pressure left atrium. Naturally, it is so much easier for the heart to just pump blood backward into that low-pressure atrium. This easy, backward path falsely inflates the apparent ejection fraction. The heart looks on paper like it's pumping super efficiently, but that preserved EF is a total illusion. By the time the EF actually starts to drop on an echo, real irreversible myocardial damage has often already occurred. Because of this sneaky illusion, the clinical presentation and imaging are just vital. On a physical exam, you're going to hear that classic pansystolic murmur radiating out to the axilla. You might catch an S3 sound, which in this context is a major marker of massive volume returning to the ventricle. You'll feel a displaced, hyperdynamic apex beat. And echocardiography is our heavy lifter here. It confirms the mechanism. Is it prolapse or is it tethering? It quantifies the exact severity of the leak, and it checks all those downstream consequences like chamber size.
So, the absolutely crucial point is, how do we use all this physiopathology to actually go and fix the patient? This brings us to Section 5, the 2025 Treatment Guidelines, which map perfectly onto the framework we just built together.
Let's synthesize the latest guidelines. If you have primary MR, the valve is broken. The undisputed gold standard is surgical repair. But if open surgery is just too risky for the patient, transcatheter edge-to-edge repair, or TER, where they go in and clip the leaflets together, is a solid Class 2A option. Now, look at ventricular secondary MR. The primary strategy isn't actually surgery, it's optimizing guideline-directed medical therapy, or GDMT, for the heart failure. But, and this is big, if they stay symptomatic despite meds, TER has been powerfully upgraded to a Class 1 recommendation based on some really robust trial data. And what about that newly recognized atrial secondary MR? Again, medical optimization is your first move. But here, surgery is Class 2A, and TER is a Class 2B option as the clinical evidence continues to mature.
A genuinely massive shift in these 2025 guidelines for primary MR is that we no longer wait around for symptoms or a falling EF to intervene. Because of that ejection fraction trap we just talked about, there is now a Class 1 recommendation to repair the valve in carefully selected, completely asymptomatic patients. To do this safely, cardiologists are now using indexed left ventricular end systolic dimensions, which basically means adjusting for the patient's specific body size, to catch early ventricular remodeling way before any permanent damage sets in.
But for secondary MR, I really cannot overstate this rule enough. Guideline-directed medical therapy absolutely must be optimized first. Fixing the valve in secondary MR is never, ever a substitute for treating the underlying heart failure. Remember, the ventricle is the primary disease here. The valve is just suffering downstream of it. Which completely resolves the mystery of our two breathless patients from the very beginning. The next time you see severe mitral regurgitation on an echo report, don't just stop there. You need to ask yourself, did the valve break the heart, like we see in primary MR, or did the heart break the valve, like in secondary MR? And if it's the latter, was it the atrium or the ventricle doing the pulling? That single distinction is the literal difference between a surgical referral, a heart failure medication plan, or a transcatheter clip. Keep this simple framework in mind, and you're going to navigate these tricky cases with absolute clarity. But it does beg one final question. As transcatheter technologies like TEER continue to rapidly evolve, will open heart surgery for MR eventually become a thing of the past entirely? Thanks so much for joining me on this explainer, and I'll catch you on the next one.